most of the common topics are covered. So just to give you a glimpse of, the problem of why we are focusing on COVID-19 and NCDs. So if you see this diagram, this is a recent, meta-analysis which is published. You will find that hypertension, the cardiovascular diseases, and the diabetes, they are the most important comorbidities which has been found in most of the countries. And from the data available in the Asia also, we have found that most of the people who have died due to the COVID, they were suffering from one or more of non-communicable diseases, and this comorbidity was important cause of morbidity as well as mortality. Next. So, what is the impact of COVID on NCDs? NCDs often require repeated interaction with the health system over long period of time. And the unmet burden of NCDs can lead to health and economic consequences at global, country, household, and individual level. And in some of the countries, we have seen large-scale migration from cities to their respective villages, and we have witnessed this phenomenon in India as well. With the rapid spread of COVID-19, the ability of the countries to address and respond to NCD has been impacted. The existing epidemic of NCD, which is responsible for 72% of the deaths globally, has been aggravating factor for adverse outcome of COVID-19. And the virus has caused broad disruption to the health services. So this is a diagram which is showing impact of COVID-19 on NCD's resources. So this is the percentage of countries with Ministry of Health staff with responsibility for NCD and their risk factor being reassigned, deployed to help with the COVID-19 response by the WHO region. So here you will find that most of the staff who was working for NCDs, they were reassigned to the COVID duties during this time. And you can see that this has happened in most of the countries. But if you see the CRO region, that is Southeast Asia region, you will find that substantial workforce was deputed from NCDs to COVID-related response, which was required also, but it has led to disruption of the services. Now, this is a diagram showing the impact of COVID-19 on NCD services, and you can see that percentage of the countries reporting the disruption of NCD related services. So you will find that most of the services, they were disrupted, which include rehabilitation services, hypertension management, diabetic and diabetic complication, asthma services, palliative care services, urgent dental care, cancer treatment. So they were adversely affected. This diagram shows the impact of COVID-19 on NCD activities, and this diagram is showing the percentage of countries reporting disruption to the Ministry of Health NCD activities planned for the current year. So during this year, you will find that there were disruption of the planned NCD activities, and this has happened in all countries, but you will find that it was very high in the Southeast Asian region, which include all of us. Next. Now, impact of COVID-19 on NCD surveillance, and This diagram shows the percentage of countries collecting or collating data on NCD-related comorbidities in COVID-19 patients. So unfortunately, uh, some of the countries, they have collected data on the surveillance for COVID-19 and NCDs. But if you see this, Southeast Asia region here, you will find that there are many countries where you will not have any data for available for comorbidity due to COVID-19 and NCDs, which is very important because it will focus the attention. Now, I have this last slide, perhaps impact on sustainable development goals. So despite the considerable progress made in the 2010 in the development, since 2010 in the prevention and treatment of NCD, the momentum of change has dwindled. The SDG target, that is 3.4 on NCD, is off track. We are lagging behind on all the global targets which are to be achieved. The COVID-19 pandemic has become an amplifier for the health system to better respond to NCDs, and there is a substantial reduction in the NCD mortality. They require a health system to deliver NCD services, which has been badly affected. So, lastly, I would like to summarize that COVID-19 has critically impacted the global health systems and economies, both in developed and developing countries, including Asia. 70% of the country reported a considerable degree of disruption of NCD services. So appropriate policy response will determine the impact of the pandemic on the human health and economic well-being. It is essential to assess the prevalent gap, the mobilization of resources, and evidence-based policy making. And of course, we all in Asia need strengthening of health system, and especially financing and effective partnership for addressing this COVID-19 pandemic and the comorbidity due to NCDs. So thank you very much. I'll stop here. It was just an overview which I wanted to share with you. So now I invite the next speaker, is Professor Sunila Garg. She has already been introduced. She's the Professor of Excellence at Maulana Azad Medical College, New Delhi, and is the President of Indian Association of Preventive and Social Medicine. So Professor Sunila Garg will give you the lesson and challenges of COVID-19 pandemic for India. So over to Professor Sunila Garg.
Thank you so much, Dr. Thakur. And as you highlighted that, NCDs especially have made a big difference to the whole scenario in terms of COVID-19, and you gave us the burden of the disease also in terms of, diabetes, hypertension, cardiovascular diseases, and across the world, how, the services with regard to NCDs have been affected, and also the systems have been overwhelmed because of, the COVID-19 and NCDs also. And on top of it, the surveillance activities have been also hugely disrupted. So that is one thing which makes it all the more very, very important. So this is, everybody knows about this novel coronavirus infection, and it's the first pandemic of 21st century. And we all know that, we had initial cases which were identified in Wuhan in December 2019 among a cluster of patients that presented with unidentified form of viral pneumonia, with shared history of visiting the non-seafood market. And virus, spread internationally within the month of, first identification, and then again, public health emergency was, pandemic was declared on 11th March 2020. That is important. And this is, I recommend to everyone that you must see this voltometer every day, and that will give you the latest, figures. And this is about 1st September. And you can see that India has got about, 3.2 crore cases, and we have got deaths about 4,39,054. And then in this, we have got also the other countries, first 10 top countries: USA, India, Brazil, Russia, UK, France, Turkey, Argentina, Iran, and Colombia. Not that the other countries are not infected. Other countries are having, are also equally progressing with the disease. But, right now, as of Indian context, in Indian context, we can say that we have got the disease under control, except for, the southern part of the country, and number of cases are accounted from Kerala. And we have got, a few upsurges in Northeast as well. And then, this is another thing which we should refer in Indian scenario. I refer it every day, but then yesterday we have got about 42,000 cases, and again, more than 30,000 cases. That is about 70% of the cases were reported from Kerala. Now, another thing which you have to remember is that the pandemic is not just a medical phenomena. It affects the individuals and the society. The behavior of an individual as a unit of society or a community has a marked effect on the dynamics of the pandemic that involves the levels of severity, degree of flow, and after effects. Now, if we see as Dr. Thakur already pointed out that, particularly in context of NCDs, the whole system was compromised. So world over, we have got, 5 strategies which were, rather implemented for prevention and control of COVID-19. Stay at home, number 1. Complete lockdown or work from home, schools being shut down, and still we are debating upon. Those schools have opened, but still, people are in two minds whether to have the schools open or closed, though our science says that they should be open. Then social or physical distancing, quarantine, testing of suspected patients, and isolation of confirmed cases. And every time we keep saying that, the public health response is that you must unlock with caution, follow hand hygiene, maintain physical hygiene, wear masks, maintain physical distance, and keep distance as to avoid, avoid distancing forever. So that's why it is important to have a physical distance, not social distance. Avoid crowds and let's protect ourselves. So these are common messages which all of you have heard, and these are important, in everyday's life also. Now, also, Dr. Thakur mentioned about, the effect of, NCDs on the healthcare delivery, and this is one of our former health ministers who is visiting. And we all know that, healthcare, delivery, our systems have been really upsurged, and the deliveries have been, healthcare delivery has been severely compromised. These measures, they cause people with comorbidities and immunocompromised people to suffer with problems like difficulty in seeking essential medical care, difficulty in getting routine medical care for NCDs, even maternity issues, issues of disabled, all have been compromised, during this COVID time. Laboratories were not diagnosing and still are not diagnosing other diseases. Health system has been rather overburdened with COVID-19 cases and cannot serve patients with other infectious diseases, which has recently started happening. More infections, delayed treatment for other infections, increased morbidity and mortality due to causes other than COVID-19. They all have been compromised. Now, also we know that there have been a lot of challenges in testing part also. We all know that testing, tracking, tracing is an evidence-based measure to curb transmission of most of the communicable diseases, and has been, rather not only in India, but of other countries also, the important resource intense activity to control COVID-19 pandemic. In all the states, the entire district administration, along with the health department, is involved in this activity. But it has not yielded the desired outcomes and has compromised on the existing programs, and whether we talk of communicable or non-communicable diseases in this context. And CA region has also faced upsurge of health systems and shortage of, testing facilities as well. Another thing is integrated response, which was also to the disease was compromised, thereby calling for an integrated plan ranging from home care in rural context to tertiary care for complicated cases. Supplies, logistics, medical supplies, PPE kits, oxygens, etc., they all required, ramping up. Community mobilization and COVID appropriate behavior continue to be essential pillars for slowing down or interrupting the ongoing transmission. But human behavior sustenance is very, very challenging. So that's where, when we talk of the disease part, when we talk of the prevention part, at the back of the mind is also human behavior, where the sustenance of this part is challenging as well. We also know that COVID-19 mucormycosis posed a threat to India and CA region, more in individuals with non-communicable diseases, and especially those who use steroids. And for long-term post-COVID symptoms, they are still a matter of concern. Emerging infectious diseases are creating further stress on the healthcare systems, And what Dr. Rai will talk about, the vaccines and breakthrough infections, they are also becoming a, important issues of challenge also. Now, if we talk of challenges in NCDs during COVID-19, already it has been pointed out that particularly, all populations are generally vulnerable to SARS-CoV-2 infections. Individuals with pre-existing chronic conditions such as cancer, cardiovascular diseases, diabetes, COPD are more likely to have severe symptoms and fatal outcomes. So what are the lessons learned for COVID-19, from COVID-19 for non-communicable diseases? Number one, like COVID-19, NCDs, they exert immense consequences on severity and progression to severe infection. The approach for non-communicable disease should target overarching systemic forces and environmental drivers, such as socioeconomic inequity and inaccessible health system, which is very, very important part. That system is accessible to few and not accessible to all. That is important. And in addition to evidence-based practices, the precautionary principle should be proactively followed in certain scenarios for non-communicable diseases to minimize future adverse consequences. Then again, we all are every day, talking about variants. We are talking about, not only variants of under investigation, variants of concern and all. Now, and now Delta plus, when we talk about the Delta variant, that is there in more than 120 countries. And India has got now 28 national laboratories to monitor the genomic variation in SARS-CoV-2. But India, including CA region, needs more labs to achieve a target of genomic sequencing of at least 5% samples. A potential variant of interest, that is C1.2, has been identified in South Africa and 7 other countries across the world, spanning over Africa, Europe, Asia, and Oceania, which again, needs to be, kind of viewed with caution, because you see, it's also highly transmissible and more infectious. The current wave is largely attributable to multiple variants, which is an issue of concern. And these mutations, they continue to pose a challenge across nations. Now, another thing which is important is that the new variants have been identified, both imported and indigenous. And then, these will continue to spread within the country, in SEA region, and globally as the pandemic progresses. But you see, India, along with other countries, also they lack genomic sequencing, particularly when we talk of SEA region in particular. Now, some of the consequences can be, they have got potential for quick spread. They can cause, milder to severe infections, potential to evade detection by viral diagnostic tests. 1.1.7 has S gene target failure, diminished susceptibility to therapeutic agents like monoclonal antibodies, and potential to evade natural or vaccine-induced immunity. That's why, now public health experts, they talk of vaccine-induced immunity also in that light, particularly when there are natural infections also. Now, another issue is that gender equality in COVID-19. The year 2020 was groundbreaking for gender equality. Instead, with the spread of COVID-19 pandemic, even the limited gains which we made in context of COVID-19, they are at the risk of being rolled back. That is where you see, from gender perspective also, we are at a loss. The pandemic of COVID-19 is deepening pre-existing inequalities, exposing vulnerabilities in social, political, and economic systems, which are in turn amplifying the impact of the pandemic. Another thing is that International Labour Organization has estimated that full or partial lockdown measures now affect, almost 2.7 billion workers, which have, still being, it's the whole loss is persistent till now, representing around 81% of the world's workforce. The situation is worse in developing economies like ours, where vast majority of the women's employment, that is 70%, is in the informal economy with very few protection, that is job security, paid leaves, etc., which also has an impact on the underlying non-communicable diseases as well. Now, if we look at the gender economics in COVID-19, further emerging evidence on the impact of COVID-19 suggests that women's economic and productive lives will be affected disproportionately and differently from men. Across the globe, we all know that women earn less, they save less, and are less secured and are infected and affected both by the disease, as they are not only suffering from the disease themselves, but they have to care for the younger ones and for the people who are elders and who are suffering from the infection as well. Now, women and girls have got unique health needs, but less likely to have access to quality health services, essential medicines, and vaccines. Maternal and reproductive health care services are compromised due to overriding COVID-19 priorities. Access and decision making to critical health services, like when we talk of maternity services or postnatal services, information about COVID-19, including health costs, are also severely affected. And this is, you can see, a major effect which has been observed now. The total effect of COVID-19 pandemic is projected to result in 13 million additional childhood marriages. A projection is well-defined intervention package to reduce, child marriage would reduce the number of child marriages by almost 60 million in the period 2020 and to 2030. And deferring the implementation of this package by just 1 year, we will have 7.4 million childhood marriages, which will not be averted. So that is why we are rolling back, in this direction because of COVID-19. Now, this part I will not be talking. I think Dr. Sanjay Rai will take care of this. But we know that, we have vaccinated over 65 crore individuals with, about first dose being about almost more than 50 crores and the second dose about 15 crores. There is a gender gap in the vaccination, which poses a greater challenge for public health. But I will like to say one thing, that vaccine strategy has to be smart and it has to be strategized for the vulnerable groups and for the individuals who require it. Another thing which has been, of crucial concern, that mental health services are severely affected. And according to new WHO survey, pandemic has disrupted or halted critical mental health services in 93% of the countries worldwide, while the demand for mental health services is increasing. There is chronic underfunding of mental health. Countries are spending less than 2% of their national health budgets on mental health and struggling to meet their population needs. Mental health services still receive less than 1% of the international aid which is earmarked for health. And a WHO survey which was conducted from June to August 2020 among 130 countries across WHO 6 regions, basically it evaluates how the provision of mental, neurological, and substance use services have changed due to COVID-19, the types of services that have been disrupted, and how the countries are adopting to overcome these challenges. COVID-19 has got, number one, it in terms of stress has affected, our lives in a major way. The physical distancing or social distancing can make us feel isolated and lonely and can increase stress and anxiety, thereby precipitating non-communicable diseases. And then again, the effects of stress, not only in terms of diseases, but there's always a fear, concentrating and making decisions, and difficulty in sleeping or nightmares. These are very, very important issues which need to be looked into. Another thing which is important is that children grows. It has resulted in common changes in children's behavior in terms of, excessive crying, annoying behavior, sadness, depression, worry, difficulty in concentration, or difficulty in or avoiding activities that they enjoyed in the past, unexpected headaches or pains throughout the bodies, and changes in eating habits also, which are also precursor for, the foundations of these could be precursors for non-communicable diseases in the later stages of life. Another thing is that the elders and people with disability at risk, they've also been more vulnerable to COVID-19 outbreak. Number 2 point is physical isolation at home amongst family members can put the elderly and disabled persons at severe mental health risk issues. It can cause anxiety and distress and induce a traumatic situation for them. Elderly people depend on young ones for their daily needs, and self-isolation can critically damage a family system. Family members may witness any of the following changes to the behavior of the older relatives. Could be irritating or shouting behavior, could be change in their sleeping or eating habits, and could be emotional outbursts as well. And there is major challenge of stigmatization also, which has been observed in this period. Generally, more people recently released from the quarantine can experience stigmatization and develop a mix of emotions. Everyone may feel differently and can have a different welcome by the society when they come out of the quarantine. People who recently have recovered may have to exercise physical distancing from their family members, not the social distancing, friends and relatives, to ensure that their family safety because of unprecedented viral nature of the disease. Then different age groups respond to this social behavior differently, which can have long and short-term effects. Another thing is that we all know that health workers who were trying to save lives and protect security also experience, physical distancing, changes in behavior of the family members, and stigmatization also. And they were suspected of being carrying COVID-19. And previously infected individuals and health professionals may develop sadness, anger, or frustration because friends or loved ones may have unfounded fears of contracting the disease from the contact with them, even though they have been, determined not to be contagious. Then another thing which is very important is that one is to remember that during the pandemic times, infodemic has been quite common. The pandemic required a strong public health strategy. System strengthening is the need of the hour. Stigma discrimination needs to be combated. All intervention should be backed by science. During COVID and post-COVID infections, non-communicable diseases have to be managed effectively. Mental health services need to be strengthened. Then testing, treating, and tracking and vaccination needs to be smart and strategized. Schools need to be open strategically. Every state is unique, and every country is unique, so the interventions have to be unique. Let us go back to our basics, that is yoga and exercises. Now, another thing, these are 4 key messages. Take breaks from watching, reading, or listening to news or stories, including those on social media. Make time to unwind, connect with others. While social distancing measures are in place, try connecting online through social media or by phone or by mail. So I'm sure that together we can, address this pandemic of, not only COVID-19, but the associated burden of non-communicable diseases. And these are some of the ways in which you can relax, mentally and physically. So come and let's, unwind ourselves. Thank you very much. Thank you.
So thank you, Professor Sunila Garg, for nicely covering the challenges which India, one of the big country in the Asian region, is facing, and you have nicely covered the challenges related to the healthcare delivery system, the challenges in testing, mucormycosis, breakthrough infections, the emerging variants, gender issues, lockdown issues, and also the workforce issues, and women, girls, especially the additional child marriages, mental health issues, elderly, and also the stigma which is involved with this disease, and also mentioned that how these could be addressed. So I'm sure there might be some questions. I'll request the participant to put it in the chat box, and we will take it at the end. Now moving to the next topic, that is experience of addressing the COVID-19 pandemic and diabetes in Philippines, and we have Professor Cecilia Jimeno, who is the professor and chair of Department of Pharmacology and Toxicology in the Department of Medicine, Division of Endocrinology. Over to Professor Cecilia.
Thank you very much for the kind introduction. Allow me to share my slides. I hope you can hear me well.
Yes.
Okay, thank you very much. I'd like to thank the Federation for this invitation to also share our experiences in the Philippines. And I was really very happy to come after Dr. Garg, hearing the similarities between India and the Philippines. For example, the stigmatization of having COVID, the stigma for healthcare workers, and even the mental health issues. So very quickly, I'd like to share this about my country. We are a population of almost 110 million people. And just to locate the Philippines, in relation to India, for example, and Indonesia and Thailand, our population is actually relatively young. But if you take a look at the epidemiology of diabetes in the Philippines, we actually have an increasing prevalence, which is happening in just the last 10 years. So that if you take a look at the red bar, you can see that we have a prevalence of around 8% for diabetes in the Philippines. But we also have around 23% prevalence of pre-diabetes. So that if you total that, that's around 30%. No? And therefore, approximately 1 out of every 3 Filipino adult actually has some form of dysglycemia. And the presence of this increasing prevalence of diabetes, we think, closely parallels the increase in the overweight and obesity rate in the Philippines. So that if you plot the prevalence of diabetes, you can see that the rapid rise in diabetes prevalence closely followed the increase in the obesity. So I'm telling you all of this so that you can get the context of what was happening in terms of diabetes in the Philippines before the COVID pandemic hit us. So diabetes was the #1 cause of death in the Philippines in 2020 after other non-communicable diseases like ischemic heart disease or neoplasms or CVD. And in a survey that we did, practically only 15% of our Filipino patients actually have good glycemic control. So it's in that particular context that COVID-19 hit the country. You know, we have a high prevalence of diabetes and pre-diabetes. We have poor diabetes control. We have high cost of medication, so that the greater majority of people with diabetes are actually unable to afford medications, and so government partly provides it. Diabetes is the 4th leading cause of death and is the #1 cause of end-stage renal disease and non-traumatic amputations. And at that time, before COVID hit the Philippines, diabetes screening was already being ramped up in our barangay, or what we call our villages, through a version of the WHO package of essential interventions for non-communicable diseases, what we call PhilPen. At the time also, when COVID-19 hit us in 2020, most healthcare spending was actually out of pocket, and even now, because universal healthcare is still to be implemented. So it is in that context that COVID-19 hit us. And so like what our 2 doctors have already previously told us, there was really disruption of the treatment and prevention of non-communicable diseases in our country. And even in terms of reproductive health, there are many unintended pregnancies. These are the worldwide numbers, no? But in the Philippines, it's anticipated also that there will be many unintended pregnancies. And so the challenge really is like in most countries where healthcare resources are limited, the focus on trying to control the pandemic will shift the attention from other areas of concern, including the routine care of those with long-term conditions, such as the different non-communicable diseases. And so they have a tendency to be neglected, no? And in the long run, could lead to increased mortality and morbidity. So here is our challenge in the Philippines. As of the moment, we already have a total of 2 million cases since it started. And as of today, we are still having a surge of 16,000 new cases in the Philippines. But our biggest challenge is that for the last 500 days, we have been in one form or another of a lockdown. No? So this long lockdown has really led to a decrease in the mobility of our patients, no? And it impacts on individual patient health as well as public health. So patients are unable to consult for healthcare services. They have decreased physical activity and exercise. They have poor access to healthy food, and most of the food that's being given for assistance are actually canned goods, no? And this has, I think, led to a weight gain and halted screening efforts for diabetes and other NCDs as patients stayed home because of the lockdown. Another challenge is, again, the efforts to control the spread of the virus has shifted care from controlling NCDs. So much of our health financing has gone to controlling the virus rather than controlling the NCDs. Many of our healthcare workers who used to screen NCDs are now trackers, no, of those who have the virus and vaccinators. And some of our programs, like our insulin program for the indigent, have been temporarily discontinued. And so, like what our two previous speakers have said, the health inequalities have been magnified by the presence of the pandemic. Now, the lockdown has also led to a loss of livelihood for many of our fellow men, our fellow countrymen. And so this led all the more to inability to sustain consultations and medications. This in the background that our medicines are already quite expensive, both in the public and private sector. And in the public sector, even if it's cheaper, the availability is actually poor. And so again, in the background of poor glycemic control, that's how COVID hit us. In the background of those with diabetes are typically overweight and obese, they have hypertension, and they have complications. We know, no, we have tried to analyze that, and we publish actually an article on this in our own journal of the ASEAN Federation of Endocrine Societies in 2020. And we now have some lessons that we have learned as we are battling with the COVID-19 pandemic. And these are lessons for our managing persons with diabetes. So we needed very quickly to come up with guidelines on treating patients with diabetes. We only have very few endocrinologists, and many of those who are managing persons with COVID and diabetes are actually internists, pulmonologists, etc. So we needed to provide them guidelines for managing diabetes because of the effects of the steroids, or even many patients who develop diabetes emergencies because of COVID. And so we had been able to then publish in our own hospital a guideline that we had disseminated to the rest of the country through continuing medical education. Our other lesson is in the Philippines, there's a lot of usage of the internet, a lot of usage of social media, which can be also a bad thing because we have a lot of infodemic or disinformation, but we can also use it for telemedicine in order to provide continuity of medical services. We can use it for triage of those who are very sick who need to be admitted. And we can use social media for not only initial consultation services, but to educate patients and for advocacy for persons with diabetes as vulnerable groups. So for example, we need to teach them that diabetes per se does not cause the increased mortality, but poor diabetes control does. And so we need to teach them, to empower them through social media, TV, and radio. So these are some examples of, for example, some social media pages, no, where many doctors have participated in to provide correct information and also initial consultations for patients. My own medical society, the Philippine Society of Endocrinology, Diabetes, and Metabolism, have a strong advocacy for vaccination for persons with diabetes. And we have provided also a lot of information, education for them on social media, no? Not only on Facebook, but also on Twitter and even Instagram. So because many Filipinos are on this media, we want to educate them. And so we can counteract the infodemic, the wrong information. We also have learned that we need to collaborate, for example, with government. That's one of our lessons. When the lockdown, when the COVID-19 hit us and there was a lockdown, many of our patients couldn't buy medicines because they couldn't get refills of their prescriptions. And so we worked with the Philippine Food and Drug Administration, and they were able to come up with an administrative order that allows patients to refill their old prescriptions. And so we also collaborate with providers of CME, with medical organizations in order to disseminate our guidelines. Finally, one of our last lessons is that we need to conduct a lot of research in the Philippines to be able to understand the interaction between diabetes and COVID-19 infection. And my own medical society is conducting 2 nationwide researches to understand the profile and outcomes of the Filipinos. And based on our preliminary results, it seems that we have a very, very high death rate, in terms of those who develop diabetes emergencies when they have COVID-19. I think in the survey that we did, it was almost an 80% mortality rate, and we need to understand why. And the COVID pandemic has provided us time to work on national guidelines such as the following, which we are now doing. So in conclusion, diabetes management has always been challenging in the Philippines, even pre-pandemic. The onset of the pandemic heightened the inequities in healthcare and has shifted the focus from managing NCDs, which are the leading causes of death in the Philippines, to efforts to control the infection, the COVID-19, the virus. So we need to refocus our efforts to reach persons with diabetes to prevent complications, even as we continue to fight the pandemic. That's it. Thank you very much for listening.
So thank you very much, Professor Cecilia. You have very amply highlighted the problem of diabetes and also highlighted that we still have poor glycemic control, that is of 15%, which is almost similar to what we have in India. There was a long lockdown in the country, and which has led to the disruption to the access to the services, decreased physical activity, and decreased screening services to the diabetes. There was many livelihood issues as we have experienced in India, and you have rightly mentioned the use of telemedicine, the social media, and also the collaboration which are required in this era, and also need for research as well as the guidelines which are very important for managing diabetes, because this is one condition where we are seeing a very high mortality. So thank you very much, and moving to the next speaker, we have Professor Sharmeen Jasmine. She's the head of the Department of Community Medicine, Bangladesh Medical College, Dhaka, and she will be speaking on critical appraisal of the COVID-19 pandemic and NCDs experience from Bangladesh. Over to Professor Jasmine.
Okay, can you hear me, please?
Yes, yes, Pierre.
Thank you. So I'm now going to start my presentation. Very good afternoon to everyone, honorable moderator, learned speakers, and dear audience. Welcome to my presentation on today's topic. First of all, I would like to express my thanks to the organizer for inviting me here. And before the August virtual gathering, it's a great honor for me and for my organization, Public Health Foundation Bangladesh. Actually, from before the emergence of the COVID-19 pandemic, all the people in the globe, we are actually trying hard to combat NCD. And especially the people of low and middle income countries are suffering a lot actually to face the overburden of the NCD and COVID-19. And in my presentation, I would actually focus on different areas First of all, I will talk about how both influence each other. And next, I would give an overview on the status of COVID-19 and NCD in Bangladesh. And next to it is initiatives taken to combat NCD and challenges and a way forward. So first of all, if you want to talk about how both of them influence each other, we know that here we can, this slide very well explain how COVID-19 and NCD, occurrence of COVID-19 and NCD can be explained by the web of causation and multifactorial causation of the disease. Here you can see that, and we know that COVID-19 complicates the old NCDs, and also it gives rise to the emergence of new NCDs. So, and as a byproduct also, we have increased mental health problems and other antisocial activities like substance abuse, alcoholism, domestic violence, more suicide and homicide during the pandemic period, also malnutrition, unemployment, and poverty. And we know that all these have a reciprocal relationship between them. So this is the interaction actually between COVID-19 and NCD and other non-communicable conditions. Now let's see how the multimorbidity actually affects. Multimorbidity affects the quality of life and affecting us, our social and economic status. Not only it reduces the quality of life, also it increases the healthcare dependency, and also it increases the healthcare cost. And healthcare cost in our country, if we say like the out-of-pocket expenditure is now 72%, which is a huge cost for the patient as well as for the family. And it also demands increased need of healthcare as multimorbidity or comorbidity is a multi-organ disease. It requires multitude of specialized services and treatment plan, and which is currently fragmented in countries, in different countries, also in Bangladesh. And there is no exact actually statistics of the prevalence of multimorbidity in our country, but many research findings show that it ranges from 8.4% to 53.8%. And the proportion of undiagnosed chronic condition is high in low and middle income countries, including Bangladesh. Now I will talk something about the overview of the COVID situation in Bangladesh. Actually, when it was first emerged in Wuhan, China in December 2019, we got 3 months, at least 3 months time to prepare ourselves to combat the pandemic. And pandemic was declared by WHO on 11th March 2020. So, but we failed to organize ourselves to combat the pandemic at that time. But in course of time, actually, we could tackle better this COVID situation. And very respectfully, I would like to mention the name of our Honorable Prime Minister, Sheikh Hasina, who had direct supervision on all the activities and programs related to the pandemic tackling. And here is the brief scenario of the COVID-19 situation in Bangladesh. It was first emerged in our country on 8th March 2020, and second wave appeared in 1 year later in March 2021. And we observed high detection rate and death rate in June, July, and until the 3rd week of August. It was due to the emergence of the Delta variant of the virus in our country. And from the last week of August, it started to decline both the detection rate and the death rate. And it is due to the 3 weeks lockdown period that we maintained in our country from 23rd July to 11th August. Though our people was not that much compliant to the lockdown, but definitely we found some positive effect for this lockdown observation. Then this is the statistics actually. The so far total detected cases of corona is 1,503,680, and total deaths are 26,274, and total recovered cases are 1,431,984 cases. Here is the confirmed case and detection rate starting from the 2nd week of August. We can see that from I already have told that in the last week of August, it started to decline. And you can see here that from 26th August, it has started to decline after 70 days. And detection rate is 14%, and yesterday it was 10%. Now let's talk something about NCDs in Bangladesh. It is very much neglected like other countries, also in Bangladesh. And according to the operational plan, we divided into two categories, conventional NCDs and non-conventional NCDs. Conventional NCDs are common like other countries, CVDs, diabetes, COPD, cancer, and renal diseases. And non-conventional NCDs, among the non-conventional NCDs, I like to utter road traffic accident and also health hazard due to climate changes. And here is the prevalence of major NCDs in our country in percentage, and it was published in the National Health Bulletin 2019 by the DGHS. And you can see here that like other countries, prevalence of diabetes is high. It is 6.4%. Next to it is ischemic heart disease, which is 3.4%, then COPD 2.9%, and stroke and CVD. And actually, the figure is not the exact figure actually, but in different sources, we have found that the diabetes is 7 to 8% in our country. Here you can see the proportional mortality rate, and NCD accounts for actually 67% of all deaths. And the high mortality is due to cardiovascular diseases, which is 30%, and next to is cancer, which is 12%, then 10% for COPD, 3% for diabetes, and 7% for injuries. And remarkably, I want to tell here that 26%, that means more than 1/4 of the diseases mortality are due to communicable, maternal, perinatal, and nutritional conditions, which is a mixture of both communicable and non-communicable conditions. So if I say that it is the burden, 67% is the burden of NCD on deaths, actually the actual value is more than that. This figure shows a pie diagram. It shows the major NCDs per 100,000 population aging from 30 to 70 years, and it is 398 to 503. And here you can see that the most commonest one is the CVD, which is 171.68. Then next to it is cancer, 54.98, then chronic renal disease, then COPD, and diabetes. Here, mental health disease, it is a very hidden disease in our community, and it is very much neglected among all the NCDs. And here you can see here that mental disease among the adults, it is almost 17%, and among the children and adolescents, it is almost 13.6%. Which is very much alarming. And all the NCDs, including the mental health, these are in the submerged portion of the iceberg. So that is a very alarming factor for us, and we need to have very early attention on those diseases. Now, this slide shows the impact of COVID-19 on health services and healthcare seeking behavior of NCD patients. Healthcare is a constitutional right in Bangladesh, and our government is actually implementing the universal health coverage programs. But on the onset of the COVID-19 pandemic, we observed that services for prevention and treatment of NCDs have been grossly affected. And it was stopped in some centers for a few months, and it was again resumed in October 2020. At that time, patients of NCDs were reluctant to visit the doctors, even to the hospitals. It has two aspects actually. One thing is patients were reluctant, but another aspect is that the family members of the a patient was not actually willing to take those patients who are their parents or old family members in the they are not willing to take them to the hospital because of the risk of the COVID-19 occurrence. And actually these worsen their already chronic diseases, and new NCDs remain undiagnosed for that. And gradually their quality of life was very much hampered. And we also know that in regard to this slide, I would like to say that not only the NCD services, we also observed that the reproductive healthcare services, family planning services, immunization, all these services actually, they didn't have access to those healthcare. But now these activities and programs are running, and we are now very much concerned about actually the rural people. What is the condition in the rural areas? Now let's talk about the national policies and strategies. In the national policies and strategies, we are now in the 4th Health, Nutrition and Population Strategic Investment Plan, which is from 2016 to 2021. And non-communicable disease control is the operational plan, and it is taking the stewardship role on behalf of Bangladesh government. It has some targets to achieve by the year 2025. Here we can see that what are the targets government has set to achieve by the 2025. And these, first of all, these are the common NCDs, cardiovascular disease, cancer, diabetes, and chronic respiratory diseases. And we have a plan to reduction of 25%. And also harmful use of alcohol and drugs, and 10% relative reduction. This is our target. And we have also targeted to reduce the prevalence of current tobacco use, especially in persons aged over 15 years. Then also reduction in the prevalence of insufficient physical activity, reduction in mean population intake of salt and sodium, and also prevalence of raised blood pressure, and halt the rise in obesity and diabetes. And these are the targets here. Then also the multi-sectoral action plan for the NCD control and prevention, that is from 2018 to 2025. And it has suggested involvement of different stakeholders including the policymakers and politicians. Then also strategic plan for surveillance and prevention of NCDs in Bangladesh. It identified the key risk factors and major challenges to improve the NCD management and situation in Bangladesh. Then national communication strategy and action plan for reduction of NCD high-risk behaviors in Bangladesh. It identified the areas of action to generate awareness against NCDs. Then what are the major ongoing programs addressing NCDs in Bangladesh? First is establishing dedicated NCD corners in the government facilities and equipping those facilities with necessary instruments for diagnosis, for screening, and proper management. Then Upazila NCD project. Upazila is the primary healthcare referral level in our country. So deals with developing capacity of the providers to diagnose and manage NCD, and also healthcare development project that emphasized on public-private partnership. Then among others ongoing programs, tertiary level hospitals, these hospitals actually is providing services for modern care in regards to diagnosis, treatment, and management. And in private sector and non-government sector also, there are some institutions or organizations like BADAS, Heart Foundation, BRAC, ICDDRB, Public Health Foundation. These are providing both clinical and preventive care on specific diseases with special attention to disadvantaged people. Now, the NCD control program has been incorporated with the universal health coverage, and there are some tracer indicators you can see here, but these are very much limited. The essential service coverage has to be strengthened and also it must have a wider coverage. Like here, some of the functions, human papilloma virus vaccination, it is now temporarily being stopped in our country. And also cancer screening program, we are doing non-use of tobacco, hypertension, diabetes, and depression treatment, and vision correction. What about the steps to combat NCD situation in COVID pandemic? Actually, the exact scenario regarding this situation is still unknown, and we actually communicated to the authority, and they have said that still works are going on, and they will require a few more days to reveal the scenario. Then routine activities are functional now in the pandemic period. Screening, diagnosis, and follow-up services are going in the community clinic and Upazila health complexes relating to NCDs. And digital healthcare services has expanded remarkably in our country during the pandemic period for the essential service coverage. And the digital healthcare service was introduced in Bangladesh in 2010, and within these 10 years, especially in pandemic situation, actually it has like a revolution in the digital sector. In medical education also, we started to teach our students through digital system. And government is providing also 3 common drugs for hypertension and 2 drugs for diabetes mellitus, including the insulin at the Upazila level. Some of the essential drugs are enlisted in the essential drug list, and among those, some of the NCDs are there, but there are lots of drugs to be incorporated very soon. And what are the challenges? So we are dealing with now universal health coverage until 2030, and we have some targets to achieve. So our challenge is how to ensure population coverage and service coverage without financial hardship. So population coverage, service coverage, and financial hardship reduction, that is actually a big challenge for us within our limited resources. Then provision of screening, diagnostic facilities, essential drugs for NCD at a primary healthcare level and during post-pandemic era, that is also a great challenge for us. Then inappropriate skill mix human health resources with lack of physical and financial resources. Actually, the exact ratio by WHO for doctor, nurse, and health technologist is 1:3:5. But in our country, the ratio is just reverse. We have we are producing only doctors, but we are not producing in proportion to that nurses and health technologists. So there is a inappropriate skill mix human health resources. That is a big challenge for us. And lack of collaboration for people's participation and empowerment. And during this COVID-19 period, also, we have observed in some of the areas to community engagement, people's relationships and people's engagement in the community health works. But actually, it should be on the voluntary basis regularly in combating the NCDs later on. So we must encourage our young people to actually participate in this kind of programs. The non-adherence to the healthcare required in NCDs, that is another problem, as NCD requires a lifelong care or supervision. Sometimes if they feel better for a temporary period, they stop their follow-up. They do not keep themselves adherent to the health system. So they come with complications and finally they die. So it is a big challenge for us to keep them in.
Yasmin, please try to conclude.
Yeah, sure. Then also lack of integration with medical and school curriculum and less attention to the lifestyle and modification. And my last talk is on way forward. So just I will highlight the headings later on in the discussion part, maybe we can discuss. Transformation of public health education and service, preventive cardiology, nephrology, and there are different branches of preventive aspects. So transformation of medical, public health education and service is very important. So next to it is registration of the NCD and risk factors through a comprehensive surveillance system. It has to be properly functional. And then introducing health insurance. If you want to reduce our out-of-pocket expenditure, we must adopt health insurance. And community engagement, then primary healthcare level has to be made functional and to be strengthened. Prompt digital healthcare services in hard-to-reach area. Portable health clinic, having access and availability of the essential medicines. These are also important. Integration of modern medicine and traditional medicine, and we have to recruit new posts for other multidisciplinary personnels. Then introduction of nursing and health technology that I have told, and school health program for prevention of NCDs. That is also important area for primordial and primary prevention of NCDs. And geriatric medicine is also another area to be introduced in our medical science. Then set up a roadmap for NCD's intervention for future pandemic. We don't know after COVID-19 pandemic what will come. So we must set a roadmap for to overcome any kind of situation like that, and political commitment and for implementing the universal health coverage. And this is the last slide. I would emphasize on the universal health coverage, which is our target to achieve by 2030. And public health approach is the breakthrough of NCD and communicable disease control and prevention. So that if it is the cube of universal health coverage at present, we want to go to this cube. That means where all people will be covered under the umbrella of universal health coverage. Thank you so much for your patient hearing. Thank you.
So thank you, Professor Jasmine, for nicely covering the situation in Bangladesh. What are the challenges, especially the health system challenges, very high level of mental health problems, but at the same time, you know, there are mechanisms now in place like targets, the multi-sectoral action plan, and also the communication strategies, and also some of the areas which needs transformation. So moving on to the next speaker, we have now Dr. David Ona. She's the Associate Professor of Department of Medicine in Philippines, and she's also the President of the Philippine Society of Hypertension, and she will be speaking on critical appraisal of COVID pandemic and management of hypertension. What are the lessons and challenges?
Thank you,
Dr. David.
Thank you, Professor Thakur, for this invitation, and thank you so much for inviting me. So my topic for this evening is the COVID-19 pandemic and how it affected the management of hypertension, particularly in the Southeast Asian region. So basically, this is the roadmap that the WHO, I just got this slide from them, how the COVID pandemic and the NCD epidemic have brought about a deadly interplay. So we're here since the outbreak. People with NCDs are more vulnerable to becoming severely ill or die from COVID-19. And there were a lot of, as all of the lecturers have alluded to, there are a lot of disruption of services for the prevention and treatment of NCD. So we see that long-term, there will be upsurge in deaths from another pandemic, which is NCDs. So at this point in time, moving forward, the world is at a critical junction because we need to execute a forward-looking strategy inclusive of NCDs to build back better and reach our sustainable development goals on NCDs. It has to be incorporated in the COVID-19 pandemic response. This is just to bring you back to the dashboard. This is just this morning at 6:21 a.m. There are a total of 218 million cases and 4.5 million deaths COVID. But I just want to give you to the real problem, basically, that 41 million deaths per year are from non-communicable diseases, 71% of global deaths, and that 15 million people die from an NCD between the ages of 30 and 69 years of age, and 85 of these premature deaths occur in the low and middle income countries. And we all know that the number one cause would be cardiovascular, followed by respiratory, followed by cancer and diabetes, which actually accounts for 80% of premature deaths from NCDs. So what is the relationship between COVID-19 and hypertension? As we've seen, both diseases require early detection, both diseases require risk perception, and both diseases require true disease prevalence to be able to combat both COVID-19 and hypertension. And we all know the impact on healthcare delivery. So both diseases, both COVID-19 and hypertension, and most NCDs highlighted the disparities in healthcare delivery across the globe. It left large economic footprints, and it strained a lot of health system resources. With NCD or in hypertension in general, because we were not able to control people with hypertension, then they move on to develop complications. So this has been discussed all the time, the relationship of COVID-19 and NCDs, but of hypertension, we all know that there's an increased risk of developing infection on COVID-19, and we see that it is associated with severe disease. You have hypertension with other comorbid conditions, then you're associated with severe disease. But let me go back to the context that even if we have 258 million people with COVID, still hypertension, there's 1.13 billion people worldwide with hypertension, and 2/3 of those live in low and middle income countries because there are increase in risk factors in this population. We all know that hypertension increases the risk of our complications. And if you look at in the context of the 4.5 million mortality, if you look at the global deaths by cause secondary to high blood pressure, there are a lot of 10.8 million people die because of hypertension, of high blood pressure. If you divide that over 365 days, that's 300,000 people dying a day because of high blood pressure. If you look at the economic burden in managing hypertension, you see that $370 billion annually are direct medical costs of hypertension. But if you do preventive, effective management of blood pressure, you have a projected health savings of 100 billion per year. And for every death due to cardiovascular disease, there are at least 3 deaths, up to 3 cardiovascular events incurring medical and social costs. So for the estimated cost of cardiovascular disease in low to middle income countries, it's around 2 to 4% of their gross national income. So aside from the impact on economy and impact on health, we look at the awareness, treatment, and control rates. Globally, an estimated 46% of adults with hypertension are unaware that they have the condition. 42% of the adults with hypertension are diagnosed and treated. But what is alarming is that approximately 1 in 5 adults with hypertension only have it under control. So we have a greater majority of people living with hypertension uncontrolled. So essentially, they're walking time bombs. And if you look at hypertension awareness, treatment, and control rates in many Asian countries, you see that they are low, except for those who really are in the high income countries, you see control rates that are higher, but majority is less than 50%, which is a dismal control rate. Meaning we have a lot of people diagnosed with hypertension, given treatment, but have an increased risk of developing complications. So what are the factors involved in poor control of hypertension? So we have physician factors and we have patient factors and healthcare deficiencies. But what I would like to tell everybody that before COVID, we had a lot of health system barriers in the management of hypertension. So in the low to middle income countries, there is limited access to healthcare and laboratory testing. There are inadequate resources to screen and manage. There's a limited supply of antihypertensive medications. And in the low to middle income countries, the budget for hypertension is consumed by financing its complications. We don't have a system. Some of the countries don't really have a system for clinical monitoring and performance evaluation to address clinical inertia. And then we have physician provider barriers. Basically, we have different phases of inertia, diagnostic and therapeutic. So diagnostic is a failure to diagnose or reveal uncontrolled treated hypertension. And therapeutic inertia is a failure to initiate or escalate treatment or a failure to choose the best available treatment. So if you look at data, you see that combination treatment in the management of hypertension, that in the lower to middle income countries, to the upper middle income and high income countries, only 13 to 15% of physicians start with combination therapy, less in the lower income countries. And if you look at up titration and revision of initial meds, it's only done in 15.4 physicians. And even in the European countries, there's an 85% inertia rate in the European studies. So you have physician-provider barriers wherein there's therapeutic inertia and there's limited application adherence to clinical guidelines, coupled by patient barriers. So you have limited access to healthcare services, you have reduced health literacy. There's a lack of urgency to seek treatment because hypertension basically don't really have symptoms. Adoption of westernized lifestyle, basically a high-fat, high cholesterol diet, high-salt diet. Fear of side effects to antihypertensive medications, and basically they really cannot afford antihypertensive medications, especially in countries wherein health is out of pocket, wherein there's no universal health care by government. So even before the pandemic, these are the barriers that led to poor awareness, poor control of hypertension, and preventive action. So during the pandemic, the challenges in the management of hypertension were brought about by containing the virus. So the containment measures led to lengthened time spent indoors. So basically, you have a reduced physical activity and increased strain on mental health, which might result in greater consumption of unhealthy foods and harmful use of tobacco and alcohol. Family members at our home. So basically, the people who have hypertension have an increased risk of contact with their younger family members at home. There's inadequate access to medicines during the pandemic, so there were shortage of essential medicines, and because of restricted transport and other services, it actually restricted transport facilities and family support for continued NCD care. We see patients not following up for a year or two because they had limited transport to and from the healthcare system. So during the pandemic, as I've said, we have challenges, basically health into three. It's chunked into three: health system, institution related, physician related, and patient related. So this was also alluded to by Professor Thakur initially, the diversion of finances to fund COVID in the Southeast Asian region. So there are a lot of funding initially for NCDs going to COVID-19. There were disruption of medical supply chains, and there were deferment of population level programs. So programs were put on hold because people were really glued. Resources were allocated to containing the virus and doing the COVID-19 pandemic response. So as Professor Thakur said, NCD-related clinical staff were deployed to provide COVID-19 relief. So it was NCD activities were relegated to the background. And closing of OPD clinics during surges and lockdowns. Out of the 122 countries that were surveyed, around 50% of them said that partially hypertension management was partially or completely disrupted during the pandemic. So what are other system-related or institution-related? So the social distancing protocols, limited access to care. We have strict hospital protocols. You need an RT-PCR swab, causing delays in performing diagnostics and seeking follow-up. So it made following up with the doctor or going to the hospital very expensive. There lack of hospital beds and personnel because majority of the beds were actually given to the management of severe, critical, moderate to severe COVID cases. And we have lack of personnel during the early part of the pandemic because they were quarantined. And during this time, we see an influx of our personnel, nurses particularly, to going to countries, high-income countries, to seek employment there. And there's a lack of strict stratification system to identify the need of care. So we don't have some countries don't have a stratification system wherein these types of patients go to tertiary hospitals or these type of patients go to primary care, basically. So what are the challenges in the management of hypertension that are physician related? So there was this early on in the pandemic issue with the use of RAS blockers. Early on, physicians had the fear of exposure to COVID because during the first part of the pandemic, a lot of colleagues have died because of it. Unavailability of MDs attending to patients admitted in hospitals because some of them were quarantined. And there was a difficulty in shifting to online consults, especially in countries where internet is really not reliable. Internet is not reliable, or they have to. It was a paradigm shift for the older practitioners to shifting to online consults. What are the patient-related factors? So there interrupted clinic follow-up and visits because of the containment measures and because they had fear of seeking care. Misinformation regarding RAS blockers causing them to stop their medications. Limited access to telehealth and telemedicine because not everybody are tech savvy and not everybody have access to internet. And then this was alluded to as well. There were job losses and financial stress resulting to not actually, for those who have out-of-pocket systems for not buying medications. And then there's a gap in the treatment. So this is poor adherence or poor persistence. This was the barrier before with regards to patients. So what are the mitigation strategies that were done during the pandemic? So we did telemedicine, task shifting, and role delegation. We had novel supply chain and dispensing approaches for NCD medicines. So a lot of pharmacies deliver medications at their home, or we shifted to electronic prescriptions, triaging to identify priorities, and redirection of patients with NCDs to alternate healthcare facilities. So we redirected them to go to alternate facilities to be able to seek care. So societies with regards to misinformation about RAS blockers have come up with position papers regarding this, as well as COVID-19 and relationship of hypertension. They've come up with studies regarding it. And then vaccination of healthcare workers and the vulnerable population. So what are the problems that actually was enhanced by the COVID-19 pandemic? So as all NCDs, these are the three things that we need to really do: prevention, screening, and treatment. So for prevention, risk factors are not addressed. We have low awareness rates for screening that was highlighted even before the pandemic and highlighted and enhanced during the pandemic. We had low treatment rates, low control rates, and increased cardiovascular complications in the background of COVID. So what are the opportunities for intervention for flattening the curve of hypertension and NCD complications? So we need to go back to prevention. We need to address modifiable risk factors. The important aspect is the true at-risk groups for hypertension is underestimated and non-diagnosed. As we've seen in our vaccination clinics, we see a lot of patients not knowing that they're hypertensive, becoming hypertensive because that's the only time that they were screened. We need to pursue legislation because we see that this is the way forward for addressing modifiable risk factors. Taxation on cigarettes, national salt reduction campaign, as was seen in Japan and South Africa and the UK. Promotional campaigns utilizing technology and social media. So this was done in Latin America. So they did an exercise promotion campaign through text, healthy diet and exercise, or delivery of healthy foods, and trying to do education through social media. Access to parks and green spaces in urban areas. So we need to have passes to patients with hypertension to actually have access to parks and green spaces for exercise. And then I think this is relevant right now because we need an equitable distribution of our COVID-19 vaccines against a severe disease from COVID. What about screening? So we need...
Yeah, Dr. Debbie, please try to conclude.
Yeah, Know Your Numbers campaign. So we have the International Society of Hypertension, May Measurement Month. 100 countries joined to increase awareness of hypertension. All patients, regardless of complaint, should have their blood pressure taken and screening at home BP measurement. So third would be treatment, improving framework for the treatment of hypertension. So this is the WHO Resolve to Save Lives and WHO PEN guidelines. We need to simplify treatment algorithms. So the International Society of Hypertension, global guidelines for the management of hypertension, and we're in the process of doing the Asian guidelines for the management of hypertension, and we need to utilize technology. So basically, I think the thing is we need a prevention and control of hypertension have to be incorporated in the COVID-19 response, and communities and health systems need to be adaptive to account for the needs of people with hypertension. So that's the last of my slide. I'd like to thank everyone for listening. Thank you.
Thank you, Dr. Debbie, for very nicely covering the topic. We all know that hypertension is a very important public health problem in all the countries, including Asia as well as in India. And one thing which I have observed for Philippines, at least the treatment rates are quite high as compared to other countries. that is to the extent of 75%. And also I would say that the control rates to the extent of 27%, which is higher than the other countries. In India, we have almost 13 to 15%, which is quite low. So you have very nicely covered that what are the issues and what are the challenges and how they can be taken care of. But definitely the COVID-19 pandemic has impacted the hypertension services and also the complications and led to the increased morbidity and mortality. So we come to the last speaker, which is a very important topic, that is vaccine coverage and equity issues in Asia, the evolving mutants of COVID-19. And we have a very important speaker, Professor Sanjay Rai, who is professor at the Center for Community Medicine. He also happened to be the president of the Indian Public Health Association and is very closely related with the vaccine and the vaccination issues in India and other countries. So over to Professor Sanjay Rai.
Thank you, sir. Thank you very much. Very good evening, all the panelists, ladies and gentlemen. First of all, I would like to thank World NCD Federation for giving me this opportunity. Definitely, Dr. Jesh Thakur, he deserves the thanks. Really, I appreciate his efforts. Dr. Thakur, to the best of my knowledge, the time allocated is 10 minutes, right? Am I audible?
You are audible. So
Yes, yes.
It's a 10-minute time.
yes,
As per the original schedule is 10 minutes, but I got confused because somebody took 15-30 minute time. So that's why I was not here. I was in another meeting. So sorry for my ignorance. So the topic given to me is vaccine coverage and equity issue in Asia, the evolving mutations. I will try to finish in a 10-minute time. It's 4:38, so by definitely in 48, I will try to finish. We all know though a small virus originated from China, one city of China, originated or reported. For us, it's originated. We don't know till date, we don't know the exact origin of this virus. But till such time, we do not have any other evidence. We can say that virus was originated from the one city of China and almost affected more than 200 countries within 3 months of its origin. I'm using this same slide since last almost 8-9 months. But there are two differences in this slide. First, the inference of the last two lines, that is the end of this pandemic. I used to say yes through the herd immunity, that is either through the vaccine or through the natural infection. But now, since last 2-3 months, based on the current available evidences, now the inference is entirely different. And in the last slide is on this inference. And the latest one is the figures. So these figures, like currently more than 200 million cases are reported from this entire world. And these are the reported cases. Actual number could be more than several times high than these numbers. And 4.5 million deaths. Again, these are the reported deaths. And India and all the part Asia. This disease, India is also dealing with more than 32.8 million cases till date and 0.43 million deaths in many parts of Asia also. So entire world is really crippling. And this was a big question, and even currently also, is there end of this epidemic? And I used to say yes. This is not neither the first nor the last epidemic, and we said goodbye to almost all previous epidemic. So there will be definitely end of this epidemic. We don't know when, but through, and that through herd immunity. I used to say that we'll achieve herd immunity through both vaccine and natural infection. But now I can, my inference is entirely different based on the available evidences. This is the trajectory in the many Asian country. We see almost in all part of world vaccination has started, except barring few countries of sub-Saharan Africa, where they are just going to start vaccination. So currently there are 21 vaccines approved by various regulatory authority of the various countries, and they are in the use, and more than 250 vaccines are in the different phases of the development for this SARS coronavirus 2 or COVID-19 disease. So the first one is the India. Currently our weekly figure is somewhere between, weekly average is around 40,000. We had a second peak in May, first week of May, almost 4 lakh cases per day. If you see the trajectory of India, started from the March 2020 mainly, although the first case reported in January, 30th January 2020. But actual cases started rising from the March. We had lockdown, very strict lockdown, and then we started vaccination on 16th of January. So this is the point of vaccination. When we started, that time there was a gradual decline. From September, we had around 1 lakh cases per day, which reached to less than 10,000 in February. This was the February, and then again there was a spike and second wave, and a large number of deaths occurred, large number of cases occurred per day. We reached to 4 lakh per day, and currently 42,000. Same Japan also. Japan started this vaccination during January. Vaccination on 17th February. There are many peaks in the Japan after that. Bangladesh, they started, this is the, when there was a gradual decline, vaccination started on February 7. So almost in all part of Asia, we started vaccination also in either your Pakistan, Bhutan, Nepal. So everywhere we started. I have selected only few countries, but almost peaks are almost same. So spikes are almost same. In Thailand also, this was the vaccination started on February 28, and this is the current figure. Almost Thailand is reporting 20,000 cases per day. This is the vaccine dose administered by country income group. If you see, so it's there is an inequity between high income group and low income group, upper middle income group, lower middle income group, and low income group. So majority of vaccines, almost high income countries, they have already received more than 50% of the eligible population. They have already received the vaccine. In few countries, it's almost 70%. Both doses. If it's majority of these vaccines are with 2 doses, except one vaccines, and that is Johnson & Johnson's. It's a single dose vaccine. So in majority of these high income countries, they have already received. The problem is in low income countries, they have only received out of these 5.3 billion doses, only 15 million, almost 16 million doses. There are many countries in this world, and especially in African countries, West African countries, where we have not reached it. So there is a huge demand and supply mismatch in the COVID currently. It's a very precious item, this vaccine, but we are unable to supply to many countries. So there is definitely inequity. This is the doses administered per 100 people in, I'm talking about the Asian countries. So as latest data available, Asia almost at least one dose, 60% of the population, that means 60 per 100. Malaysia, it's a one dose. So that's why the figure is even more than 100. At least one dose they have given to more than 100. So out of 100, Malaysia, Japan, Sri Lanka. India is also more than 40%. India and Thailand. Then Nepal, Pakistan, Bangladesh, and Afghanistan. And these are the number of people vaccinated against COVID-19. See the Indian figure, almost more than 60 crore, more than 600 million we have already given. And this is taken from the World Vaccine Report. So it's our World data in data. So it's not the compare, most probably it's a 2 days old figure. So currently we have crossed almost 600 million figure. But India is number one in terms of total number of cases. In terms of percentage, definitely we are far behind many countries, many European countries, and also US. Then in terms of number, India, only one country is ahead, that is the China. But China's data, they few months ago they released data, so we don't have any idea about the China. We all know this is vaccine exam. We have I have 3 more minutes. So vaccine is a safe and effective way to prevent, we all know, disease. Currently, we are using more than 20 vaccines for various diseases, and we are, it's a estimate by WHO that we are saving more than 3 million lives per day. So now we have few vaccines to make dent, and these few vaccines, 21 vaccines. Now, as I said earlier, my inference is now different. Earlier, my inference was that those who had COVID-19 infection should not be part of the priority group. But now my inference is they should not be given, because now this virus is more than 1.5-year-old virus. We have generated a lot of evidences. And we must use, as a scientist, we must use all these evidences. So during this COVID pandemic, vaccination continue to be critically important and must be provided to all the susceptible population. Whatever evidence we have globally, we can say we can save a lot of lives through vaccination. But in those who are still susceptible, those who are not susceptible, there is no additional benefit. 2 days ago, Israel, they have released data, and they have the first study, and they have compared vaccinated people with the Pfizer and those who had natural infection almost 1 year ago. Almost 1,300% natural infected people, they are better protected than the best effective vaccine. 1,300%. There are many studies. In January, one study published in your New England Journal of Medicine, they compared healthcare providers for almost 7 months, and they found that almost reinfection rate is very rare. And if reinfection is happening, then your severity is almost nil, almost zero, if you compare with the vaccinated group. So there are 3 groups: vaccinated, unvaccinated, and naturally recovered group, COVID recovered group. Then definitely those who are unvaccinated and susceptible, they are at the greater risk. Then the second group, vaccinated, they are protected and good protection. Almost we are saving 70 to 80% life, and it's a huge number per lakh in adult population. We are really protecting almost, suppose if they are susceptible population, 1 lakh susceptible population, and if you are providing vaccine, so we are saving almost 1,000 to 1,200 deaths in more than 45-year age. Almost it's a 1.5% death rate if they are not protected. So vaccine is definitely providing safety. But in case of naturally recovered, they are the best protected person on this earth, as unavailable evidences I can say. Continuation of the largest vaccination drive in India. Almost we have vaccinated more than 645 million people. There is a global demand mismatch supply, and we used to say that nobody is safe until everybody is safe. So this the global demand mismatch supply in COVID-19 vaccine is obvious. Many developing countries who cannot produce the vaccines, and they're not producing, many are not producing vaccines, have already fallen behind in this race. So there is a growing criticism of this vaccine inequality. or unequal access to vaccine between rich and developing country. So in current scenario, this vaccine is a very precious substance and must be used very judiciously. We should not waste vaccine. Definitely, we cannot waste this vaccine, this precious item. So, based on current available evidences, we can say those who had documented COVID should not be given vaccine at this moment. Till such time, we generate a new evidence that vaccine is beneficial for them. Even forget about this beneficial. Actually, it may cause harm due to few known and unknown severe events following immunization. In susceptible population, there is a huge benefit. As I have demonstrated, even suppose per million, if 2 or 3 people having this severe adverse event, but you are protecting thousands of lives. But in naturally recovered person, there is no need to, and we can save a lot of vaccine and we can supply to even third world country unnecessarily. All these are based on available evidence. This is not my reference. So this vaccine will play an important role in preventing future waves, no doubt. For the susceptible population, definitely. Based on evidences, we can say, yeah, COVID recovered patient, they are best protected person on this earth, and they have better level of protection, longer duration of protection. Even some studies have demonstrated that they may provide lifelong immunity. The another free sharing of data in public domain for researchers to predict any third wave like in India or fourth wave or fifth wave anywhere. So unlinked anonymous data must be available in the public domain so that a researcher and scientist, they can predict something not only based on the model. So thank you very much. Thanks for giving me the opportunity and your patience. Please. Thank you.
So thank you, Dr. Rai, for very nicely covering the topic in a very concise way. And you have rightly mentioned that there are many inequities in the vaccine distribution and there is a mismatch of demand and supply. You have also rightly mentioned that this documented COVID-19 infection should not be a priority or should not be given in the initial phases, as some of the guidelines in some of the countries in Asia, they include the people who are suffering from suffered from the COVID-19 infection to be given the vaccine. And also another important point which you have highlighted is the free sharing of the data and in the public domain so that researchers can use, because this public domain of data is very, very important, and in fact not only for COVID but for other conditions also. The data should be in the public domain so that researchers can use. And of course, another important message is that all the countries should try to increase the vaccine coverage as much as possible. So thank you very much, all speakers, and I'll go to the questions. There are a couple of questions, so I can start with Dr. Sanjay only. The one question to you is, Israel was among the few countries to have achieved a vaccination coverage of 78% about 12 years, yet the country is now logging one of the highest infection rate. So is it a warning sign for all other countries?
And that's why if you have susceptible population, these vaccines are not decreasing your susceptibility for the infection. They are decreasing your susceptibility for severity and deaths. Almost, if you see the breakthrough infection, even sometimes breakthrough infections are more. You just see the CDC, they have just released the data of Massachusetts. Almost 73% of infections are breakthrough infections. Breakthrough, they have clear-cut definition of breakthrough infection. For breakthrough infection, 2 weeks after the second dose of a vaccine, if it is a 2-dose vaccine, or 2 weeks after the one of vaccination, if it's a first dose vaccine, 1-dose vaccine, like in Johnson & Johnson vaccine. Majority of vaccine are 2-dose vaccine. So breakthrough infections are very common. If suppose only 40% population or 50% population have complete vaccine coverage, and if the breakthrough infections are 75%, So that means these vaccines are not protecting from infection, but whatever data we have, they are protecting from your the severity and deaths. That's why I said we can reduce a lot of deaths and severity. But in see, based on the current available evidences, either Israel or UK, US, including India, we have control in many states except Kerala. Kerala, if you see the susceptible population, as per the current latest survey, of Zero survey, only 44%. Delhi had this 51% almost 8 months back before this second wave. So there is huge discrepancy between this your coverage level. In Israel or any part of the world, if I can conclude, I can say majority of us will develop this disease, SARS-CoV-2, or will get infection even after vaccination. But vaccination is significantly reducing your death and severity. The herd immunity, the last point I forget to mention here because I was in the hurry, that my inference is different, that the herd immunity will be achieved through the natural infection, most probably based on the available evidences. I can say we cannot achieve herd immunity through vaccine. Vaccine is not protecting from the infection, and herd immunity, as per definition, indirectly you are protecting others. So only natural infection is providing better and longer duration of protection. So we will achieve herd immunity, definitely will achieve herd immunity. This will be not a problem, but through natural infection, even with all the variant, alpha, beta, gamma, delta and delta plus, all variant, the naturally infected people, those who had infection with the original one virus, even they are best protected. So we can say that, okay, either in Israel or anywhere in this country, there will be a gradually decrease in the susceptible population pool, and we'll achieve this herd immunity. So sooner or later, we will control everywhere this way.
Okay.
This is my inference based on the available evidences.
Thank you very much. Now, question to Dr. Cecilia. Are the risk of COVID-19 different for people with type 1 and type 2 diabetes? And the second question is, what has been the response of the people of Philippines towards COVID-appropriate behavior and vaccination?
Okay. So is there a difference between type 1 and type 2 diabetes in terms of susceptibility? I would think so, because persons with type 2 diabetes tend to be overweight and obese. They have hypertension, and so the risks actually compound as compared to persons with type 1 diabetes. Also, persons with type 1 diabetes in the Philippines tend to be quite young. We have a relatively young type 1 population. So, and internationally, I think it's the same. And so generally, persons with type 2 diabetes seem to have a greater risk for more severe infections, actually. Now, with regards to the uptake of vaccination and health protocols in the Philippines, there's some hesitancy in terms of the vaccination, but I think the main problem in the Philippines is not so much the hesitation, the vaccine hesitancy. It's actually the availability of the vaccines. At the current time, although a lot of vaccine doses have arrived in the Philippines, there are more people who want it than the availability of the vaccines. And that's our main problem at the moment. I think we're already convincing people to get vaccinated, especially those who are vulnerable, like persons with diabetes, except that at the moment, we still don't have enough supply of vaccines.
So to Professor Sunila, how public health personnel can play a role to relieve the mental health agony of the geriatric population during COVID-19 pandemic? And another question is, will the personality, that is the communication skills, teamwork, development of the preschool children be affected due to the prolonged stay in a controlled household environment rather than the school environment?
Thank you, Dr. Thakur. First of all, I'll say that, when we talk of the old people, we talk of young old, old, and very old. And when we talk of, young, old and very old persons, here public health professionals have got a very, very critical role in creating, first of all, the awareness and sensitization of family members. You see, ultimately, what leads to the mental health issues is, you are alone, you are thinking yourself, and plus, looking at, kind of the overall scenario through TV, media, and all that. So that's where we have to impart correct information. We have to impart correct information regarding COVID appropriate behavior. The third is that they also should be involved in the family activities, and also, children have got a special role to play within the household settings, that they should not be left alone. And when you are exercising, when you are doing yoga and all that, involve your elderly people also, involve them in many things. They've got wealth of information to sensitize us, to create, to give us information rather than we giving information. So public health professionals definitely at all levels, right from frontline workers till the end, I'll say till the topmost specialists, have got a very critical role to play, that your elderlies are a valuable asset. Now, the second part, you said that, it's been a long time, almost 1.5 years, and India is the only country where the schools have been closed, and especially with regard to preschool children also, where they used to go out, and receive, supplementary nutrition and non-formal education through the Anganwadi workers platform, or even child to child contact in the school, or child to teacher contact. This is something which we have lost, and that is where we cannot have a trade-off between the education, child's development, or the growth and other milestones with vis-a-vis the school closure. There cannot be a trade-off between the two. So that's where it is very, very important that the schools have to open very soon, and we need to sensitize the important stakeholders that open with caution, open with COVID appropriate behavior, because in children the ACE inhibitors are very less, and the infection is also very less. So they recover very fast, and that's how for influenza also, before the vaccine came, the herd immunity came, because the schools were not closed, especially for younger children. So it's very important that we look from this perspective. Thank you so much.
Thank you very much, Professor Garg. Coming to Dr. Jasmine, what are the challenges in Bangladesh to use the telemedicine services during the lockdown, and also how do you reach the marginalized and illiterate section of the country? And another question is how the professional societies can play a role in ensuring that the effect of COVID-19 on NCD is minimized.
Okay, thank you so much. Actually, telemedicine service, I said that it has been introduced in our country in 2010, and many of our health workers, especially who are in the community clinic and also in the Upajala primary level of healthcare delivery system who works there, they were trained. And during the pandemic situation, actually, we found that actually when they could not come physically, then government have decided to expand the service through the digital healthcare. And we have a A2I, that means access to information. It is a project, and also in the district level we have district health information system too, where we could get data from there, and from that data we could generate many information, evidence-based information to the common people. So expansion is that many, especially if a health service and health education, even in the general school also, we have started the digital, digitally we could educate the children in the school and colleges and medical colleges and universities as well. But main thing is that you have asked me that the hard to reach areas people. So there are some limitations, but in some community, some we have actually community engagement programs were adopted, and so group by group children were collected and they were provided these digital healthcare services. And in our future plan of action, this during the pandemic period, we are expanding our this kind of digital health programs. So this is one thing. And your second question was when we'll understand that. Second question was when we'll understand that
Professional associations.
Excuse me.
How the professional societies can play a role in ensuring that the effect of COVID-19 on NCD is minimized.
Okay. So at least at our professionals, like health professionals, they have started in a public level and a public sector and private sector. They have started consulting the patients and also to the healthy people who are in need of healthcare, and they are getting different kind of services. But for that reason, we need to have a very extensive research actually. So in some sporadic researches are being going on. So the published result could tell us actually what is the exact situation of COVID rightly at present. But what we are now watching in our society, that the detection rate is now coming down. Also the death rate is coming down, and vaccination program is accelerating so fast. And by the year 2020, our government has decided to make the population to be covered by vaccination, about 80% coverage of vaccination. I think that will altogether will actually help us to assume that COVID-19 situation has been tackled down. Thank you.
Now, the questions to Dr. Devi. Does the hypertension medication in turn increase the risk of having a COVID infection and increase the severity of the complications? Another question to you is also there are reports of people with a high BP to defer their vaccination. So is there any evidence available for that?
So basically, the first question was already debunked by all of the societies, international societies from all over, that there is no evidence that your RAS blockers have really increases the risk of developing COVID. There are studies, RCTs being done right now all over the world to actually try to give you hard facts and hard science behind all of these. But if you look, all of the societies have actually made their stand that there is no really evidence that your antihypertensive medications increases COVID. With regards to your second question, what was your second? I'm sorry. Your second question
was pertaining to there are reports of people with the high blood pressure to defer their vaccination. So is there any evidence?
I think most of the societies also in all area in Asia have actually developed position papers regarding this. So high blood pressure is not really a contraindication for vaccination, except that in instances wherein they are in hypertensive emergency. So meaning this patient's blood pressure is associated with target organ damage like stroke, heart failure, or acute LV dysfunction, etc. So these are the ones that have true contraindications to vaccination. What we are seeing is that there is really underreporting of the true prevalence of hypertension. So I think we need to make these vaccination area opportunities for screening patients and trying to educate them to actually seek the help of the doctor, and or all of the people should really know what their blood pressure is before going to a vaccination area, basically. So I think it's an opportunity for screening everyone so that we can prevent the complications associated with uncontrolled hypertension.
So thank you very much. We have almost, over our time, but if there is any one or two quick questions which those who has not listed in the chat box, they want to ask before we close this session. So there were certain comments also. We really thank the people, and especially Dr. Sanjay Wadhwa from All Indian Institute of Medical Sciences. Rehabilitation is a very important area and should also be addressed. So I take this opportunity to Yes, thank you very much. So I take this opportunity to thank all the speakers, Professor Sunila Garg, Dr. Cecilia, Professor Jasmine, Dr. Devi, and Dr. Sanjay Rai, very nicely covering their respective topics and bringing the issues which are confronting in the Asian countries. And in fact, our problems are same. We have a high burden of non-communicable diseases, and at the same time, we have also the substantial burden of COVID, and it has impacted our services very badly, and also the services for NCD related services, they have been affected. There had been the livelihood issues in many of our countries, and because we have many vulnerable sections in the societies, and we have also observed that there is a mismatch between the demand and supply as far as vaccination is concerned, and there is also inequities in terms of the delivery of services as well as vaccination. So we hope that we will be able to increase our vaccinations in our respective countries, and at the same time this herd immunity will play an important role. Some of the countries are now experiencing the increase in number of cases, and especially 1 or 2 states in India are also experiencing, which is a matter of concern. But collectively, by learning from each other and by sharing each other's experience, I think these partnerships are very important, and our effort is that this issue of comorbidity due to COVID-19 and NCD is brought forward, because this is one area where we have seen that most of the morbidity and mortality in most of the countries are among the people who were having non-communicable diseases. So we need to address this issue. I take this opportunity to thank all the participants who have overwhelmingly participated in this, the webinar. And of course, this will be available, all the presentation and the speech lectures will be available on the website of YouTube link of the World NCD Federation, which we have shared with you. So once again, on behalf of World NCD Federation, I thank all the speakers for being us, and all the participants for participating in this very important seminar, and all of us take forward the message which we have got from this, that we need to fight this pandemic and especially address the issues which are related to the comorbidity of COVID-19 and non-communicable diseases. Thank you very much, and with this we close this session.
Thank you.
Namaskar, सभी लोगों को thank you.
Thank you very much.
Thank you.
Thank you very much.
See you again.
Thank you. Regards, everyone.
Yes.